Good afternoon. So in this, we welcome you to the OT2, and here Dr. Surendra Prakash will be operating a case where the patient has some lens matter dropped inside his eye, and there are some cortical matters in the anterior chamber as well. Dr. Aditi, will you elaborate on the case?
Definitely, sir. So first of all, we would like to welcome Dr. Surendra Prakash, sir. He has completed his long-term fellowship in Vitreoretina subspecialty under the mentorship of Dr. Rupa Kanti Biswas and inherited the skills of Vitreoretina surgeries. He has worked as visiting Vitreoretina consultant at Purnima Netralaya, a center of excellence in ophthalmology in Jamshedpur, and Eye Foundation, Purulia. So here's a look at the case. So the plan for surgery is right eye vitrectomy plus nucleus removal SFIL under local anesthesia. A 58-year-old male. Right eye cataract surgery done elsewhere on 29 November 21. History of nucleus drop. So right eye vision is counting finger 1 feet. Slit lamp examination, aphakia, cortical matter in AC. IOP 23 mm of Hg. Fundus very hazy. Here's a look of the slit lamp exam. You can see the cortical matter in the AC. And here's a fundus examination, fundus view.
So Dr. Surendra will make the flaps for the SFIL first, and then he will go for the vitrectomy and other steps. So he is doing that conventional suture based SFIL. So at this point, I would like to ask Dr. Sudipto that what is his preferred pattern, preferred technique of SFIL these days? Is he still doing sutured, or he has moved on to sutureless SFILs? Dr. Sudipto?
Thank you, Saurabh, and I think a very nice video already is being done process. I would just share a few things. One is that I still prefer to do sutured SFIL in patients where it's a long-standing case where you have a long-standing aphakia. Few cases I have started doing this secondary sensor implantation, intrascleral flanges. I have started doing, especially intraoperatively when you don't have a backup of SFIL. But I still do both the procedures. I do prefer both the procedures.
Great. And this making the flaps before starting the vitrectomy is very crucial, because you need a firm globe to make these flaps. So once you have done vitrectomy, there are chances of having hypotony, and flaps can become difficult to make. So that's the right approach, and so here it goes. And I would like to ask Dr. Love, because he is the prolific pediatric cataract surgeon in this part. So Dr. Love, when do you advise secondary IOL or SFIOL? Sorry, not secondary, but SFIOL in a child? Like, do you have any cutoff for the age?
Generally not before 6 years of age, but if you can push it to 8 to 9 years, it would be better. 6 years only when it is gross, and mainly SFIOL what we do is for subluxated IOLs. So
okay,
around my comfort is more around 8 years of age.
Great, sir.
Sure, one point I just wanted to make, probably for the beginners who are starting doing sutured SFIL, it's better to have a marking, because for experienced people, we have an eye estimation. But otherwise, I think it's better to have a marking with RK marker to get exactly centered SFILs in sutured SFIL.
Correct, right. That's a fair point. And what kind of flap do you make most of the times? Do you make a triangular flap or a rectangular flap like Surendra Prakash made.
Yeah, I usually prefer to do a rectangular flap, but I usually make it with blade instead of crescent, so that we get only one point to suture instead of having separate two sutures, or maybe one suture, because these flaps sometimes you get elevation on both sides, so you can
Right.
have a single suture at one end.
Okay. And any experience of using glue to flatten these flaps, or you always suture?
No, I used to do glue. Maybe it's non-availability and the cost sometimes, but it's always much better if you have glue. In that case, you can suture, you can reposition the flap, you can reposition the cornea, conjunctiva also with glue.
Correct. Right. Okay, so we are here for some surprises. Surendra Prakash has just informed us that apart from lens matter, there is an IOL also inside the vitreous cavity. So here you can see that. So Dr. Surendra is trying to free the IOL from the vitreous attachments. That is most very important, because if we start to pull the IOL out without freeing it from the vitreous, then there are risk of retinal detachment, retinal tears. So the IOL has to be free, floating, then it should be tried to remove out.
And sure of in this scenario where you have a foldable IOL in vitreous, then it's better to have a sutured SFIL, because anyway you have to open the wound to remove it. So the foldable sensor probably will not be of much benefit when you have an open wound.
Correct, correct. So this surgery is being done on Constellation, 25 gauge vitrectomy with 10,000 cut rate, and the cutter has the tip which is beveled, and it is little closer to the cutting edge is little closer to the tip, which would enable the surgeon to go much closer to retina than before. So which gauge do you prefer, Dr. Sudipto, when you do such cases, 23 gauge or 25 gauge, and what would be your reasons?
Most of the time, sure, I have shifted to 25 gauge for almost all the surgeries, because even in high myopes, except in very high myopes, probably you can get away with 25 gauge. So I still prefer to do all 25 gauge, except until unless you have a large nucleus chunk where you need to have bigger sclerotomy to introduce the phragmatome. I usually prefer to do 25 gauge.
So now Dr. Surendra is trying to remove the lens matters which are there, and IOL will be taken after the removal of the lens matters.
Saurabh, can you just give some detail about the microscope, operating microscope also?
This is Zeiss Lumira 300, and yeah.
So I just I think there are a few reports about fixing the C-flex also in through scleral fixating in technique. Saurabh, you must be Saurabh, you must be aware of this C-flex 4 point fixation. So they are passing the switches in the loop to fix it.
Right.
Both the loops.
Yeah.
Both
So
the
let's
loops.
see here what Dr. Prakash is up his sleeves.
So he can utilize this lens also if he wants to.
Sorry, I could not get you. Can you repeat again? Yeah.
No, I was just. Saurabh, am I audible?
Yeah.
So I think there are a few reports about fixing this C-flex Renner in through scleral fixating technique by 4-point fixation with cut sutures. I think you must be aware of.
Yeah.
Though you have never tried, I think this particular lens was being used in that technique.
Correct. Yeah, but I also I have not done that, and I would probably rather remove and put a rigid SFIL.
True. I think I also would be more comfortable.
Yes.
Not putting this foldable lens through suture.
And ultimately, it becomes a matter of surgeon's confidence and convenience. If you are convenient and confident, then that gives a better result. I think so.
Yes, absolutely.
So now we are moving to the crucial phase of the surgery where IOL will be removed. And earlier we used to use LPFC to float the lens matter or float the lens or IOL and then remove it when probably we are using 20 gauge surgeries. So Dr. Sudipto, have you now in the era of small gauge vitrectomy, have you ever used LPFC recently off late?
To remove the to float the IOL or the nucleus?
No, float the hard nucleus.
Yeah. No, I have not used because most of the time, if you meticulous vitrectomy, once you do a very meticulous vitrectomy, if the adhesions are not there, then fragmentome is good enough to bring it in the mid-vitreous cavity.
Yeah, and the issue remains that if you are going to use fragmentome, we have to enlarge the port, one of the ports. Yes. That's an issue. Yeah. So now the vitreous skirt is being removed. So now hold your breath. The IOL is going to be lifted and brought into the antechamber. This is a coordinated step between assistant and the surgeons. The forceps used for lifting this IOL was Alcon's Max Grip forceps. And there it goes. That's how it happens. Many a times you have to give more than one attempt because it's not just lifting the IOL. You have to do it very safely, and surgeon, as Dr. Prakash is going to do, try to be as safe so that the retina and rest of the things do not get damaged. Again, the issue of 25 gauge instruments being more pliable and tend to bend comes into play when we are going to lift such solid things from the vitreous. So, Dr. Sudipto, do you think that 23 gauge instruments which are more sturdy than 25 would be better in this such scenario?
25 gauge, I think it should help, because now the newer instruments are quite okay, and especially in these foldable lenses, even you can pinch at one edge of the haptic, you can lift it. The prerequisite, what I feel, is that you should actually have a AC entry before that, and you should have a viscoelastic injected in the anterior chamber, and keep it hold it until unless you can push one of the haptics in the anterior chamber. Once one of the haptic is in the anterior chamber, you can actually, in the under microscope, you can dilate in the AC and then enlarge the anterior chamber, the wound, and remove it.
Right. So the other theater is ready, and we'll probably switch over to the next OT, where next case is going to start now. Yeah, so the IOL has been removed and SF file has been placed. So now we are at the fag end of the surgery.
That was quite fast, Surendra.
So he is thanking his mentor for the swift surgery which he just did. So Dr. Surendra will be here with us to share his experience in a bit. So, Dr. Sudipto, do you make scleral tunnels in such cases, or you go clear cornea into the anterior chamber? What is your preference?
I think we both, Surendra and me, have one thing in common. We have learned the initial surgery from the same person. So I follow the same scleral tunnel technique. I don't go a direct entry. A lot of times you can go away with one suture also, if the tunnel is good and you have very minimal astigmatism.
Right. So for the beginners, what would you suggest? Because sometimes the SFIL needle gets entangled into the scleral tunnel, and so it becomes little messy, and sometimes it can bleed and cause hyphema postoperatively. So is the clear corneal entry better for beginners, or tunnel is always good?
I think tunnel is always better, because for beginners the clear corneal entry and the suturing also will have significant astigmatism. Tunnel, one is we can actually put a central suture before passing the other sutures, which actually will guide you and to avoid entanglement. And second one, you can use a flat spatula to guide the needles through the tunnel, so that you don't have any engagement in the corneal tissue.
Great.
I'll also add one thing, Saurabh, that I use. I feel probably it's a 90 prolin being used for SFIL, because I have not seen that part.
It's a 10-0 prolin only.
Okay.
10-0.
Because right now I have shifted to all 9-0 because of seeing almost around 10 years after surgery, we are seeing breakage in almost around 10-50% patients of SFIL.
So any specific reason for shifting to 9-0 instead of 10-0 proline?
I am seeing breakage after a long term, maybe around 10 years, 12 years follow-up. We are seeing a lot of patients being done by somewhere else 10 years back. We are getting breakage at least 1 point, and then you have to redo the procedure. I don't have any 10-year follow-up for 9-0, but I think probably it's definitely it will be helpful.
Yeah, that's quite logical that 9-0 would probably last longer than 10-0.
Yes.
Right.
Because very tight sutures also can give a cut through later. So it's more with 10-0.
So would there be any chances of exposure of these sutures 9-0 because they will be thicker? Exposure from the flap.
Yes. No, I think you can bury the knot intrasclerally.
Okay.
So that you can do with the entry where you enter with the 26 gauge needle. So that is a little bigger bore. So you can actually bury the 9-0 proline also. So in that case you will have less suture exposure.
Fine. Thank you. So now we'll move to the OT1 where the next surgery is ready, and we'll talk to Dr. Prakash afterwards. We'll move to OT1.